For colorectal cancer screening with CT colonography, size is the most important feature to decide if polyps should be removed. And we already know that polyps of 10 millimeter and larger have a high chance of being an advanced adenoma, so they should be removed. We already know that polyps smaller than 6 millimeter have a low chance of harboring advanced histology, so we can ignore those. But debate remains about the 6 to 9 millimeter polyps, and little is known about their natural course. So the purpose of my study is to evaluate the natural evolution of these medium-sized polyps, and in order to do so, we assessed the volume of those polyps and the change in size during the 3-year surveillance interval. And we know that from previous research that the volume measurements are more reliable than linear measurements, so that's why we used the volumetric measurements. And then we correlated the volumetric growth to the histopathology findings in order to see if we can predict which polyps are at risk of becoming advanced. Yes, we performed a prospective study in surveillance patients, and we derived those patients from a primary colorectal cancer screening program. They participated in CTC then, and we invited all patients with 1 or 2 6 to 9 millimeter polyps after 3 years for a surveillance CTC. We performed a low-dose CTC protocol scan, and patients were referred for colonoscopy and polyp removal if they had 1 or more polyps of 6 millimeter and larger. Retrospectively, we assessed the volume in the polyps on initial and surveillance CTC. And we did that with semi-automated automated measurements, where we were able to manually correct the boundaries per volume of the volume per slice. Then we assessed growth over the 3-year surveillance interval in percentages, and an increase of 30% or more was classified as progressing, a decrease of 30% or more was classified as regressing, and everything in between as stable. And then we correlated the growth of the polyps to the histopathology findings. Well, the main finding of our study is that the majority of the 6 to 9 millimeter polyps will not progress to advanced neoplasia in this 3-year surveillance interval. We saw that 22% of those polyps were advanced adenomas at removal, and we didn't find any polyps with high-grade dysplasia, or we didn't find any colorectal cancers. Those that did progress to advanced adenomas can particularly be found among the progressing polyps, but there were 1/3 of advanced adenomas that remained stable during this surveillance interval, and that's an important group that has not been described previously, and we didn't find any regressing advanced adenomas. Well, my research has the potential effect to affect clinical care, in that current European and US screening guidelines advise to refer all patients with a polyp of 6 millimeter and larger for colonoscopy. And well, the main finding of my study is that the majority will not progress during a 3-year surveillance interval to an advanced adenoma. So well, that places the current guidelines into perspective, and we've shown that the 3-year surveillance CTC screening strategy is a safe strategy because we didn't find any colorectal cancers or high-grade dysplasia adenomas, and this could be therefore a viable alternative to the colonoscopy referral.